Thank you for inviting me for this important meeting. I am Chang Hyun-gang from Seoul National University Hospital. Today's talk is about the neoadjuvant treatment in thymic epithelial tumor. Advanced thymic epithelial tumors are presented in 10 to 30% of the patients, and neoadjuvant treatment is usually considered in unresectable or marginally resectable cases. Currently, neoadjuvant chemotherapy or chemoradiation is available, and the goal of neoadjuvant treatment is to improve complete resection rate, because improving complete resection rate is directly related to the improved survival. However, currently there is no evidence of the superiority of neoadjuvant treatment over upfront surgery. What is the indication of neoadjuvant treatment in thymic epithelial tumor? Probably some patients with advanced T3 and most patients with advanced T4 may be candidates for neoadjuvant treatment. However, if you look at the involved organ in thymic epithelial tumor, lung and pericardium are most frequently involved organs. So these two organs usually not neoadjuvant treatment is not necessary. So what is the indication of neoadjuvant treatment is still controversial. And this is a paper from Japanese National Database, and this paper included 310 patients who received the surgery with the advanced T stages. And then in this paper, usually most of patients received upfront surgery. Only a small number of patients received induction chemotherapy. And this paper shows the larger resection rate according to the invaded organs. According to this paper, lung and pericardium shows a very high rate of complete resection rate. However, great vessel and praying nerve and chest wall invasion showed a less favorable complete resection rate. So according to this paper, we can think the great vessel invasion, praying nerve invasion, and chest wall invasion may be candidates for the neoadjuvant treatment and surgical resection. The chemotherapy regimens used in thymic epithelial tumor is very limited. And this paper reviews the currently available chemotherapy regimens in the thymic epithelial tumor. And the most commonly used regimen is number 1, 2, which is called as CAP regimen in our hospital. However, in this paper, it was described as a PAC, PAC. This regimen is a combination of cisplatin, doxorubicin, and cyclophosphamide. And sometimes some researchers added steroid, or some researchers added radiation therapy. The next most commonly used regimen is ADOC. ADOC is adding the vincristine to CAP regimen. This is the second most commonly used regimen. The other regimens in number 4 is a very rarely used regimen. So usually in clinical practice, the CAP or ADOC are most commonly used regimen. And however, this paper summarized the chemotherapy regimens in the palliative chemotherapy setting. So the response rate, they're adding their CR and PR ranges from 30% to 90%. However, most papers, there are more than 50% response rate has been reported in this review paper. Although previous papers reported 80 or 90% response rate after chemotherapy, it is hardly to believe in neoadjuvant chemotherapy setting, because this data is from our hospital. We analyzed, reassessed the response rate after reviewing the chest CT scan. And in the medical record, there are many descriptions about the course of the patient. It is a partial response after chemotherapy. However, we assessed the exact size of the mass change, and then we can identify only small numbers of the patient shows objective response, a partial response according to the RECIST criteria. Just a subjective description, and they show it was a 80% response rate. However, according to RECIST criteria, we could identify just 29% of the response rate. So in terms of response rate, is a little bit disappointing result after neoadjuvant chemotherapy, and the RDO resection rate was 75% in our hospital. The low response rate after neoadjuvant chemotherapy also can be found in pathologic result. This paper included 49 patients who received the neoadjuvant treatment and assessed their pathologic response, and proportion of TRG1 and TRG2 was just 16%, because in terms of the pathology response, we can say the TRG1 and TRG2 is a major response. However, the proportion of major response is quite low, and considering the significant number of major response in lung cancer or esophageal cancer. So according to the radiologic and the pathologic data result, and we can say the neoadjuvant chemotherapy response is just modest, not great in thymic epithelial tumor. And what is the result of the neoadjuvant treatment in thymic epithelial tumor? And this is a paper published in 2016, and they included 12 papers published from 2003 and 2014. And as you can see in this meta-analysis, the involved patients number is quite small in each paper, only just from the 10 to the 30 patients. However, they reported the average value of their complete resection rate, and RDO resection rate was 73% after induction treatment. The 73% of the complete resection rate may be not so high than our expected value, because in the previous slide I showed that in Japanese national database the complete resection rate was more than 70% in just the upfront surgery. So I think that it is unclear whether the induction treatment can improve the RDO resection rate or not, according to this paper. In this slide, I summarize the recently published papers about the neoadjuvant chemotherapy or chemoradiotherapy, and in these papers included larger patients than the previous papers. However, the outcome itself, the RDO resection rate, was not improved, because they reported around 60% of their RDO resection rate. The rest of the paper, published in 2019, is my paper. Then we included 109 patients who received the chemotherapy and compares the propensity score matched the 109 patients who received the upfront surgery. And because in our group the advanced stage rate was more higher, the stage 4 is 58%, and the RDO resection rate was 63%. In this paper, we compare the overall survival and recurrence-free survival between the upfront surgery and induction treatments. According to our paper, we could not find any difference between the upfront surgery group and induction treatment group. Currently, I think we don't have enough evidence that induction treatments improve the patient's survival or recurrence. So we need more studies on this issue. The other option in induction treatment is a neoadjuvant chemoradiation, and currently we have two papers published. One was published in 2008 and one was in 2013, and both of paper reported around 40% response rate and around 80% of the RDO resection rate. And in terms of the RDO resection rate, the proportion of RDO resection rate is very promising. However, the second paper is a multi-center trial, and however the mortality rate was 9%, relatively higher than the previous reported series in induction chemotherapy arm. So we can say that an induction chemoradiotherapy may have the potential to increase the surgical risk. In our hospital, We are also performing the neoadjuvant chemoradiation, and more than 20% we could identify the response rate was 36%, arterial resection rate was 91%. In terms of arterial resection rate, this is quite good. However, we have also mortality. The 4% of mortality was identified. So the selection of the neoadjuvant treatment currently is quite controversial. The induction chemoradiotherapy can improve the arterial resection rate. However, it harbors significant mortality after operation. So we need more study on this issue furthermore. The other option is neoadjuvant immunotherapy. However, currently we don't have enough evidence on the immunotherapy in thymic epithelial tumor. The hypothesis is that the strong expression of PD-L1 in thymic carcinoma may be beneficial for the use of the induction immunotherapy. However, it is well known the high rate of autoimmune complication, especially in thymoma after immunotherapy. So the result is somewhat mixed. And currently we have two papers on the immunotherapy on thymic epithelial tumor. Both of papers was used for the palliative immunotherapy setting. And the response rate was around 10 to 20%, and autoimmune complication rate was 15 to 71%. In terms of the response rate and autoimmune complication rate, and the response rate is not so good compared to the previous report, chemotherapy and chemoradiotherapy, and higher autoimmune complication rate was reported. However, we have only small numbers of the patients. We need more papers on this issue. So I must conclude my talk. And neoadjuvant treatment, especially chemotherapy, can be delivered in case of marginally resectable thymic epithelial tumor. This is a very common practice. However, the response to chemotherapy is modest, and overall survival benefit is unclear currently. Neoadjuvant chemoradiation can be considered as an alternative treatment. However, increased postoperative complication and mortality should be considered. The ultimate goal of induction treatment is to increase the complete resection rate, and surgeon should play a main role when selecting proper treatment for the patients with advanced TT. Thank you for your attention.